with 40 days amenorrhea, presence with abdominal pain, spotting per vaginum, and her systemic examination revealed nothing special. Uterus is normal size and fornices are free, and pregnancy test is positive. Kameshwari madam, how will you proceed in such situation?
Any reproductive age group women with missed period, positive test and pain or spotting, we must suspect an ectopic pregnancy. So as you have rightly put there, we would first do a scan. If there is a sac located, then problem solved. But as you have written there, no sac, intra or extra, then you need the beta HCG.
Yes, madam. So the main problem now here comes is beta HCG is only 1200. So what is the diagnosis you can put forward?
We can't say anything just based on one beta HCG. Yeah, especially when it's below the discriminatory zone. Generally, we take 1500 as our cutoff. So I would ask for a repeat in 48 hours. Till then, it is pregnancy of unknown location.
Yes, this is a pregnancy of unknown location. And always you should remember that it is a transient state. It can go to an ectopic or it can go for an intrauterine pregnancy. So you can ask, as soon as the patient is stable, you can go for an expectant management till a definite diagnosis is made. So you repeat beta HCG after 48 hours. And so we often say that there will be a doubling in 48 hours. But you must make sure that it depends upon the initial level. If the initial level is less than 1500, then comes to around 50%. Whereas if the initial level is 1500 to 3000, it may not be 50% rise. It may be around 40%. Whereas if the initial level is more than 3000, the rise may not be of 50%, it will be 33%. And so then what is the discriminatory zone? No, sir?
This is the zone at which you would expect to see an intrauterine pregnancy. Generally taken is around 3,000, 3,150. And at that level, you expect to see 99% of intrauterine pregnancies. In some centers, it's as low as 2,000, and you may just see the smallest possible sac. Now, because heterotropic pregnancies are extremely rare, the moment you see an intrauterine pregnancy, the assumption is that you have ruled out an ectopic.
Yes. So here the main problem here is if you keep discriminatory zone so low as 1500, you will detect an intrauterine pregnancy to the tune of around 80%. Whereas if you keep it as 2000, it will be around the tune of around 90%. But if it is kept at 3510 or 3500, and you will be able to diagnose ectopic intrauterine pregnancy to the tune of around 99%. So that is, you may miss only 1%. That's the importance of keeping an elevated level of discriminatory zone. Yes. Then repeat HCG, and it comes above the discriminatory zone. How you are going to proceed, Dr. Radhamani?
One thing before diagnosing pregnancy unknown location, I would like to say the quality and resolution of the machine, the experience of the person who did the scan, and also with the one transvaginal ultrasound, you can never say it is ectopic because the adnexa may be placed high up. In that case, we may miss with the transvaginal ultrasound, so an abdominal ultrasound also is needed. And another thing is, it is not a definite diagnosis pregnancy. Only with the follow-up, we are able to come to a definitive diagnosis and repeat ultrasound.
Yes,
so the possibilities are with the follow-up. Either maybe it is an early intrauterine gestation, maybe live or an embryonic, and or maybe if the HCG is rising again, if it 1:66, it is intrauterine. Less than 1:66 is extrauterine. Less than 0.8, it is pregnancy unknown location. These are the possibilities when on follow-up.
Yes, the main point here is with single beta HCG, you won't be able to diagnose anything. You will have to have repeated HCG values to come to a definitive diagnosis. And here, repeated HCG was done and it came as above the discriminatory zone. So the possibilities here in this, it can be either intrauterine pregnancy or no intrauterine pregnancy, so much so it may be an ectopic pregnancy and clinically stable. So say the patient after 48 hours, 3,500 and more than 3,500 international unit, clinically stable, and you can diagnose unruptured ectopic by way of ultrasound. And how will you manage, Dr. Nusser?
Thanks to early diagnosis by ultrasound, today we have the option of medical management, which I believe should be the treatment of choice. And medical management is methotrexate. It's well established, it's extremely effective. A single dose suffices, a dose of 1 milligram per kilogram body weight with a maximum dose of maybe 100 milligrams. I personally do not do a double dose unless a week later I find the pregnancy to still be there and I find that the HCG levels haven't dropped. If you test too early, and generally at day 4, you might find a small spike in HCG, and do not let that change your method of management. You have to be patient. It takes about a week for methotrexate to start showing its effect. Follow-ups by beta HCG, you have to have a falling trend. At some point in time, she is going to bleed when the pregnancy is no longer viable, and that's when you reassure the patient and inform her in advance to anticipate vaginal bleeding and to understand that what she's bleeding is not because of the pregnancy being expelled, but because of the decidua being expelled, since you have a fall in the hormone levels.
Yes, the main problem regarding the medical management is either you can go for the single dose or you can go for the double dose or multi-dose. I too prefer single dose or multi-dose depending upon the level of HCG. If the level of HCG is high, I prefer to go for multi-dose regimen. That is 1 milligram per kg of methotrexate on 1357 of and folinic acid 0.1 milligram per kg on 2468, and this 2468 you will follow up with HCG. And if you are doing single dose, you will follow up with beta HCG on day 1, day 4 and day 7. If there is a fall by 15% from day 4 to day 7, you can see that the pregnancy is being managed, ectopic pregnancy being managed well with your methotrexate. So if the patient, there is no question of doing an ultrasound and or doing a pervaginal examination. This follow-up is only by beta HCG as far as the patient is clinically stable. If the patient is clinically unstable, then you may change your management. So if a patient is clinically stable patient, with you can very well manage with methotrexate. Even though the textbook says if it is less than 5,000, less than 3,000, you manage with medical management. But we can manage provided you know the patient is clinically stable, willing to come to follow up, and also no other contraindications are there. Before starting methotrexate, you have to give, you have to go for the complete hemogram, LFT, RFT, and also make sure that patient is not having an active lung disease or active peptic ulcer. So these are, and also patient is not breastfeeding. These are the definite contraindication for giving methotrexate. And we are giving methotrexate. It is not the high dose which is often given for malignancies, not the low dose which is given for in rheumatoid arthritis. That is, we are giving a dose intermediate between the two. That is, if it is single dose, it is 50 milligram per meter square. You can calculate the surface area and then you can give the methotrexate. So then another option is surgical. Kameshwari madam, what surgical options you will prefer when the patient is clinically stable?
In our institute, medical management comes first. If people don't fit the criteria, or they have symptoms of severe pain, or they are unable to come for follow-up with medical, then we offer surgical, and laparoscopy is the gold standard. In almost 99% out of 100, we do laparoscopy, and whether we do salpingectomy or salpingostomy, again, depends on the patient's situation, her parity, her desire for future fertility. If the contralateral tube is healthy, then we go for salpingectomy. If the contralateral tube is also unhealthy or absent already, then we try to save this tube with salpingostomy. However, they need follow-up with beta HCGs later to ensure that the trophoblastic tissue has diminished altogether.
So as you want to, if you are going for salpingostomy, you should rule out persistent ectopic by way of HCG estimation. So that is often seen with very early ectopic, which may not have been removed completely by the dissection. So most of the time with salpingostomy, what happens is bleeding may come more and more, and you can even use vasopressin to decrease the bleeding prior to going for the incision. Then repeat beta HCG is below the discriminatory zone, then comes the problem. How will you manage, Dr. Nusser?
So if you don't get the rise that you expect and anticipate, then you are probably pointing more towards an extrauterine gestation. And at some point in time, you have to make the decision. You can still go on with your expectant management and wait for the beta HCG to start decreasing. Whenever you have a pregnancy in an unknown location, interestingly, about 10 to 15% are ectopic initially, maybe about 25% are intrauterine, but the remaining will remain in an unknown location. In many of these patients, the HCG might just fall away, and there's nothing more that needs to be done. You don't need to give methotrexate to every patient. But in this situation, if it persists, and if on more than 2 occasions I keep getting a titer which is not giving me a conclusive rise, then I will treat this as an ectopic pregnancy, even though there is no ultrasound visualization. And if I don't have a significant fall, I will go for medical management.
So if it is below the discriminatory zone, there are 2 schools of thought. You can give methotrexate and then finish it off. Or else, if you want to avoid that methotrexate dose, you can go in for D&C. That is, if the patient is having a pregnancy which is undesired, or a reasonable diagnosis of failing intrauterine pregnancy, you can make by your ultrasound. And you can go for a D&C and look for the chorionic villi by floating test. Or another important factor is if you do D&C and repeat the beta HCG after 24 hours, if the fall is more than 50%, you are more or less assured that it is a failed intrauterine pregnancy and there is no need for further treatment, and you can safely send the patient home with follow-up. And suppose there is a plateauing or rising, then you give methotrexate, considering it as ectopic. And if the fall is between 15 to 50%, it can be a failed intrauterine pregnancy or it can be an ectopic. Then you can follow up with beta HCG. If there is no decline, you can give methotrexate.
I think with high resolution ultrasounds and beta HCGs, the role of DNC has come down drastically. We rarely do DNCs now.
So I am saying if the patient, if somebody is in the periphery and also doing such, may not be having such high-end machines, then in such cases, if you are more in favor of intrauterine pregnancy, then there is absolutely no contraindication going for intrauterine evacuation and then looking for the beta HCG.
And if a chorionic villi is present, it is called histopathologic pregnancy.
Now, see, you can go for floating. You may not. If you go for hydroflotation, that is, you put the specimen in saline and see the villas are floating or not. Then it's not for histopathology.
Yeah. So I don't do DNCs.
Okay.
For me, manual vacuum aspiration is the way to go.
Yes, you can
You
go
get the best possible villi, and even when I'm doing a surgical management of an ectopic pregnancy, I will do a manual vacuum aspiration.
Yes.
And that's partly because now she doesn't have to wait for the bleed. You've kind of completed the process at the same time.
Yes. The same patient, HCG is 4,000, clinically unstable. So there is no ambiguity. Radhamani.
See, so we know that she is a pregnancy unknown location. Always hospitalize the patient during the observation time, so that it is easy to tackle the situation when the patient is unstable. So it is ruptured ectopic, unstable ruptured ectopic, and we immediately start the gray cannula, and then everything should be arranged as early, as quick as possible to move the patient to the theatre. Simultaneously, you arrange the blood and blood products if needed, and then theatre should be ready, and then we have to go. Always, if it is unstable, it is open. Ideally open, even
Yes.
though you are skilled enough to do, we are very skilled laparoscopist.
Yes,
Open
sir.
surgery is the ideal thing. So
And,
immediately after opening the abdomen, never waste time to suck out the blood.
Yes.
You hold the uterus in your hand and then identify the bleeding site and clamp, the blood pressure will rise.
Yes. So you have, the main objective is you open up the abdomen and find out the bleeding site and just give a pressure on that side, either by clamp or by your fingers. It will rise the BP and it will save the life of the patient.
And then partial salpingectomy is the procedure.
Yes,
there,
you can go for the segmental resection or complete excision of the salpinx. Then just a few, there are, ectopic can be in any sites. Then the most important one is the cesarean scar ectopics, and another is the interstitial ectopic. The interstitial ectopics, Kameshwari madam, what is your take on this interstitial ectopics?
Interstitial ectopic was previously called as Cornwall, which is not the case. That is number one. And here the sac is located in the intramural portion of the tube. So there are some clues on ultrasound, as you have rightly placed there. You find an empty uterine cavity. The endometrium and the sac, the distance between the two is called the interstitial line. You look for it, and generally you notice that this is surrounded by myometrium all around, unlike the angular pregnancies. The differential diagnosis angular pregnancy, that is located close to the cavity but towards a corner. There you find that it is surrounded by endometrium on one side and myometrium on the other. This one has myometrium all around, easily diagnosed on ultrasound if you look for these features.
So what is the management, madam?
Medical management,
Yes.
usually.
What about new, sir? Management for interstitial?
I believe the first line treatment for ectopic pregnancies has to be medical management.
Yes, 100%.
Surgical management becomes your next step. And I'd just like to say, because we mentioned, madam very rightly said, you're perfectly justified in doing a laparotomy. But today, with the skilled laparoscopic surgeons that we have, if the patient is stable enough for your anesthetist to give you an anesthesia, laparoscopy is your solution. I don't remember having done a laparotomy in the last 25 years, even with a hemoperitoneum of 1.5 liters. You just go in, you just go straight for the bleed, you go for the tube, get the bleed controlled, and then you take your time doing the lavage. The whole surgery will be over in 20 minutes or 25 minutes. And I think in terms of recovery for the woman, it will be much, much better than having to do a laparotomy. But if you don't have those skill sets and you are in the periphery, then without hesitation, a laparotomy is justified. Do not struggle at doing a laparoscopy if you feel you don't have the capacity of doing it very quickly.
Yes, 100% right. Regarding cesarean scar ectopic, Dr. Radhamani?
Yeah. The cesarean scar, it is increasing because in it 1 in 1,500, 1 in 2,000 incidences. There are two types, type 1 and type 2. Type 1 is endogenous, that is it grows towards the cavity, and type 2 is exogenous, it is grows towards the scar and it may protrude outside into the bladder. And this is how to diagnose on a panoramic longitudinal sagittal scan. Divide the uterus into half by an imaginary line perpendicular to its longitudinal axis and determine the location of sac in relation to this line. Mark the center of the sac, and if the center of the sac is above the line, it is intrauterine, and below the line is cesarean scar pregnancy. Exceptions are there, but other findings are bladder line irregular or disrupted, sac bulging into the bladder, there is negative sliding organ sign, and also MRI is indicated when there is CSP is large and when in case of fibroid.
Yes, associated with fibroid. You
3D also is a supplement, but it is not recommended
mandatory,
usually.
yes.
Mandatory.
So how will you manage scar ectopics?
And management can be medical, surgical or combined. Again, depending upon the type, if it is endogenous, we have to counsel the patient that if she wants to continue the pregnancy, there is a chance of pregnancy, placenta accreta spectrum and associated hysterectomy. Otherwise, if she is willing for termination, ideally better is you give methotrexate and surgical evacuation after uterine embolization if facilities are available. If facilities are not available, you can suction evacuation and then put Foley's tablet, or else you can even go for Shirodka suture apply it, and then after suction you tie it, so that hematoma forms will access the tamnate.
Yes,
Exogenous, actually, surgery is needed for exogenous, either laparoscopy if you are skilled, or if not, actually open. One more thing is, if there is a products of consumption is retaining, hysteroscopy is also advised.
Yeah, most of the time we may have to go in for combined. Dr. Nusar, what about cervical ectopics? What is you can diagnose mainly by ultrasound?
That's right. It's an ultrasound diagnosis, a much dreaded condition. People used to, dread treating a cervical ectopic. I'd just like to share that while medical management remains first choice, in these cases, the entire cervix is barrel shaped, the pregnancy is below the internal os. There are all the criteria you have. But again, thanks to modern ultrasound, you pick them up quickly, you pick them up well, and then you just get on with treating it as soon as possible.
So we have done a hysteroscopic resection.
Yeah, so I'll just tell you that over a period of time, we've had 7 cervical ectopics. In fact, for me now, hysteroscopy has become my first line of treatment. Now, I know it might sound a little aggressive, but after going through medical managements and initially doing hysteroscopy for failed medical managements, when we now go in with hysteroscopy, of course, you have to be able to operate in that very limited space in the cervix. That's how you see the gestational sac. The procedure just proceeds like any hysteroscopic resection. You're being very focal. Those are the chorionic villi. This is one of the largest cervical ectopics we had, where you can actually see the embryo there. And you go in and you resect it down to the cervical tissue. You will see it. And towards the end, you will have a few bleeding vessels. Under vision, you fulgurate them. These patients have the procedure and are home within 12 to 24 hours. They are completely dry. And I've had patients who've gone ahead, and one patient who's given birth twice vaginally after a cervical ectopic being done hysteroscopically. It has been documented, it is there in literature, and definitely consider this as an option if you have the hysteroscopic skills.
Adamani had a few cervical ectopics.
I had 11 cases for the last 4 years, and I was able to successfully manage all these cervical pregnancy by ligating the descending branch in the Indian iliac artery, and only one case I gave uterine embolization, and after this 24 to 48 hours, suction evacuation, and then Foley's. Or else you can even put a pack inside the cervical canal, or you can inject vasopressin. That will so successfully manage 11 cases, and out of one case, again heterotropic, with the cervical abortion and growing intrauterine pregnancy. I only ligated the Indian descending cervical, nothing did for the cervical, and that intrauterine pregnancy grown and delivered at 34 weeks because of the preeclampsia, and now the baby is fourth birthday is celebrated.
Sir, sorry to interrupt. Actually, the time is over. Can you please conclude the session?
Yes, I am concluding, and you have heard regarding the various types of ectopics, how it is managed. Most of the time, it is managed medically, and at times you may have to go in for surgical management, and or even combined medical. And so the mainstay here is the treatment with methotrexate. There are other drugs which are also coming up. Some are using geftinib. It is a epidermal growth factor receptor inhibitor, and another is letrozole. These are some drugs which are coming up for management of ectopic pregnancy as well. Thank you all.
Thank you, sir. I request the lead
I
discussant.
thank all the my panel members, esteemed teachers, for giving their valuable opinion and suggestions. Thank you.
Request the lead discussant and the faculty to go to the photo session, to the photo corner.
All the smiles of a positive urine pregnancy test fades when the woman bleeds in the first trimester. And if she ends up in an abortion, we are faced with all questions: why it happened and will it happen again? To tell us on this, we have the lead discussant, Dr. Parvati Dutt from Ernakulam Medical College. I'm inviting Dr. Parvati Dutt to the dais. And also we have invited faculty, dear Lakshmi Madam, and also Dr. Nosar Sharir. Sir, please join after the photo session. Over to you, Parvati, and I'm requesting you to kindly keep up the time. Thank you.
Madam Nosa, sir. So good morning to you. Good morning to all.